My goal before I retire is to do one of these lectures in Spanish. My wife's trying to teach me, but I'm a good student of the liver, but I'm a poor language student. But someday I'm going to give you a lecture in Spanish, which will be a treat. But today it's in English, and we're going to review direct-acting antivirals in 2017. And as you know, a lot of work has been done, and we're actually in the 9th inning of direct-acting antivirals. Most of the work has been done, and now as cure rates approach 100%, we're really in a position where we should be able to cure almost every patient with hepatitis C in the world today. Obviously, the goal now is eradication from the world. So if I retire and I make hepatitis C like polio, where it's now extinct from the world, I'll feel like I did a good job over my academic career. Well, let's dive into it. As you know, I'm involved in all the direct-acting antivirals with all the companies. I'm so conflicted. I'm not conflicted anymore. I work with everybody in the field. Why is it important to treat hepatitis C? Well, it's not any surprise. We've known this since 2012 when the famous JAMA paper from Vandermeer came out, where we saw improvements not only in liver-related complications, be it liver cancer, liver failure, liver-related deaths, but also improvement in all-cause mortality. So by treating and curing hepatitis C, we improve we decrease mortality in patients and improve patients' lives and certainly improve their liver status. So in order to do that, we're obviously in the world of direct-acting antivirals, and there's really 3 classifications of antivirals that have been used in development today, and you know them, the protease inhibitors, the NS5A or replication complex inhibitors, and the nucleotide and non-nucleotide polymerase inhibitors. So these are really the 3 classes. All these drugs have been now brought to the market and are labeled in the US. So as you can see, the field is getting very crowded with a number of antivirals, particularly in the protease and the NS5A domains. So if you're astute and don't really follow the literature or don't necessarily know the names, you can still figure out what class a drug belongs to by looking at the root of the word. As you can see in the red, all the protease inhibitors end in Previr, all the NS5A inhibitors end in Asvir, and the nucleotide polymerase inhibitors in Buvir. So by looking at the root of the word, you're actually able to identify what class each antiviral comes from, even if you're not familiar with the antiviral itself. You can estimate what class the drug belongs to. So I'm not going to go through the first wave, as I've discussed with you a few times in the last couple of years. Obviously, the first wave of combination antivirals, including sofosbuvir, ledipasvir, paritaprevir, ombidisvir, dasabivir, and simepivir and sofosbuvir, in a genotype 1A environment have really shown us overall 95% success rates, right? As we emerge now with newer antivirals, we're bumping the SVRs from 95% up to 98 to 100%. But even in the world of the first generation antivirals, we were able to get to 98 to 100%. Where were we able to get 98 to 100% even in the initial antivirals? These were 1B patients. So a little easier to treat, more responsive to antivirals. So even the first wave drugs gave us 98 to 100% when you looked at studies that were 1B specific, albeit we didn't do that many 1B studies only, but if you look at 1B studies, genotype 1B, you're able to see cure rates of 98 to 100%. Now, as we'll discuss towards the end, now even in genotype 1A patients, we're achieving 98 to 100%. So those were the first wave. This is kind of an in-between antiviral where it's not a new generation. It's not quite second generation, but it's an evolving first wave combination. Grazoprevir and elbasvir is one of the newer combinations after those first 3 waves, and really is no different than the table I showed you where the overall SVR or cure rate is 95%. And you can also see that just like all the first wave drugs in genotype 1B patients, you achieve that 98 to 100% threshold, and in 1A patients, you fall back to 92% in this particular combination. Why is that? Is this combination is particularly impacted with baseline NS5A resistance. The other topic that's very interesting is when you use a protease, so grazoprevir is a protease, elbasvir is an NS5A, and you know that by the root, right? Previr protease, Asvir and NS5A. When you look at a protease inhibitor as part of the combination, we see that cirrhosis and non-cirrhosis are equilibrated with overall SVR rates, whereas you can see in cirrhotic patients 97% versus 94% in non-cirrhotic. So when you have a protease inhibitor as part of the combination, probably because the protease inhibitors concentrate in the liver, you actually get a little more bang for the buck, as we would say in the US. You get a little more activity with the protease inhibitor concentrating in the liver and probably giving you a little more benefit in cirrhotic patients. So the big problem with this combination is you really can't use it if you can't access NS5A baseline resistance testing. Why? Because if you don't have baseline NS5A resistance, you get a 98% cure rate in genotype 1A patients, which is great. But if you do have baseline NS5A resistance, remember the classic positions 28, 30, 31, and 93. And if you have those baseline resistance and you use this combination of a protease and an NS5A in a one-pill combination for 12 weeks, you get to only a 70% SVR. And for me, that would certainly qualify as a super no bueno response rate, right? We don't like 70%. I don't have many Spanish words, so I'm showing off my one or two I have. Sorry about that. So, but if you extend, if you take those patients with NS5A resistance and add ribavirin and go longer, you can increase the SVR to 100%. So, albeit it's a small cohort, if you have baseline NS5A resistance, you either have to consider a different combination or add ribavirin and go longer. So that's why the label in the US supports 16 weeks with ribavirin in patients with baseline NS5A resistance. If you don't have baseline NS5A resistance, you use the one pill a day for 12 weeks and get very good results at 98%. The real step forward with this combination has been in the setting of advanced kidney disease, CKD stage 4 and 5, demonstrated by the C-SURFER study. Both of these combinations are hepatically metabolized and not renally excreted. Thus, this C-SURFER study looked at both cirrhotics and non-cirrhotics with advanced kidney disease. And this was really a breakthrough therapy because in genotype 1A, we had no ribavirin-free DAA combinations for patients with advanced kidney disease, so this was the first opportunity to treat genotype 1A, particularly with advanced kidney disease, and the cure rate was 99%, 115 out of 116. So these CKD patients, stage 4 and 5, remember CKD stage 4 is a GFR below 30, or patients on dialysis achieved universal success, and these certainly kidney disease patients are fairly sick, yet they all responded with the exception of one single patient. So this was really a huge step forward for patients with advanced renal disease, and the grazoprevir and albazvir has been an important step forward for those patients. We tried to shorten therapy by adding sofosbuvir, the grazoprevir, and albazvir, even trying to get down durations as short as 4 weeks. And with the therapies we had at the time, we couldn't quite get there, right? 4 weeks wasn't very effective. It's only a third of patients responding. But you can see there is a huge fall off with duration. As you increase duration, even getting out to 8 weeks in cirrhotic patients, you can see now at 8 weeks you've achieved very good rates of SVR with 3 antivirals, adding sofosbuvir, a polymerase inhibitor, to the NS5A and the protease. In the cirrhotic patients, we were able to get all but one cured in a small cohort, really representing that adding antivirals can shorten duration of therapy. The next antiviral of interest, or in chronologic order, is sofosbuvir and valpatisvir, nucleotide polymerase inhibitor in NS5A. This was demonstrated as in the phase 3 program called the Astral program. This is a fixed dose combination of sofosbuvir and valpatisvir, a single pill for 12 weeks, and this was studied in the Astral program. So Astral 1 looked primarily at genotype 1, albeit it did look at all the genotypes, but was focused on genotype 1. Astral 2 looked at genotype 2. Astral 3 looked at genotype 3, and you may think Astral 4 looked at genotype 4, but they broke the rule here. It wasn't genotype 4, it was actually decompensated disease. Why they didn't name it something different, and I don't know, but they messed up the pattern of remembering the Astral program. But let's go through some of the results briefly. Here's Astral 1. Again, it was a placebo-controlled trial of 12 weeks of sofosbuvir and valpatisvir versus a control arm. And what were the results? Results were highly effective, right? So this is the introduction of cure rates of 98 to 100%. We draw a line here, all therapies going forward from valpatisvir, sofosbuvir on now really have to reach a 98 to 100% success rate to really be competitive in where we're treating today, and valpatisvir and sofosbuvir led us to that. So in genotype 1A and 1B, there was one failure in each arm with over 330 patients, with only one 1A failure and one 1B failure, with an overall success rate of about 99% in genotype 1 patients. In the genotype 2, 4, 5, and 6, there were no failures with a 100% cure rate. Genotype 3 was left out of Astral 1 because a whole study was dedicated to genotype 3, being Astral 3. And knowing that was going to be a little more of a problematic population, they chose to just study it alone in Astral 3. But really, very nice results with only 2 genotype 1 virologic failures and no failures in genotypes 2, 4, 5, and 6. Again, with cure rates now 99 to 100% across these genotypes. And safety-wise, in the world today, safety of antivirals, these are very safe, and most of them look like placebo. This is no exception. This was a placebo-controlled trial, so you can look at placebo patients and compare what the addition of an antiviral regimen did. And you can see that the overall rate of adverse events in placebo and active are very, very similar. And I don't have a slide on it, but if you broke them down into individual adverse events, in general, the rates of adverse events are looking pretty similar to placebo, with a mild increase in adverse events in combination therapy. The thing I always like to look at is how many people discontinue due to adverse events, because you can look at the percentages in a number of ways, but what you can't put in any certain light is how many patients stop therapy. If they come from one appointment on therapy and the next appointment off therapy because they couldn't tolerate the therapy, there's no way to hide that in the numbers, and that's also a very important number to me. So if you look at the active DC due to adverse events, it's 1% in the active arm, and actually a higher discontinuation rate in the placebo arm. This is a double-blind randomized trial, so the patients didn't know if they were getting placebo or not, but they knew that if they finished therapy, they would eventually get the active drug if they were on the placebo. So really, again, very, very few adverse events and very few discontinuations. So how about those genotype 3 patients? A study was dedicated to them called Astral 3. This looked at 12 weeks of sofosbuvir and valpatisvir and compared it to a control arm of 24 weeks of sofosbuvir and ribavirin. And this study had up to 30% cirrhotics and otherwise had a demographic pattern that looked pretty similar to patients we treat today. So what was the results of Astral 3? Overall SVR rate of 95%. So now we see the world of 95% or higher, even in the setting of genotype 3, which has been our most problematic genotype to treat in the hepatitis C world. And that compared to, that compared to an 80% response rate in sofosbuvir and ribavirin. So in genotype 3, it's still not, we're not getting that 98 to 100%. There's still work to be done even in this combination, right? In genotype 3, there's 2 factors that really fall out in a lot of studies. Are you cirrhotic or not? And are you treatment experienced or not? And you can see in the treatment naive populations, if we only focus on the light color bars, if you're a treatment naive, cirrhotic versus non-cirrhotic, you can see a fall off in the presence of cirrhosis both in treatment naive and in treatment experience. If you have the combination of treatment experience and cirrhosis, you're actually still not quite hitting 90%. So that's still, even in the great therapy that we're seeing 99% response rates in most of the other genotypes, if you're a genotype 3 cirrhotic who had failed PEG interferon and ribavirin, you're still not quite getting above 90% with this combination. So prior to sofosbuvir and valpatisvir, what was our standard of care for genotype 3? It was decladisvir and sofosbuvir, right? And the registration trial called Ally 3 overall had a 90% response rate in treatment naive and in 86 in treatment experienced patients. But as another US expression, the devil is in the details. In sofosbuvir and declatosphere, really the importance was were you cirrhotic or not. If you were non-cirrhotic, 12 weeks of declatosphere and sofosbuvir really gave you a great response rate of 98% in treatment naive patients and 94% in treatment experienced patients. I'll tell you to remember that 98% for another slide down the road. So overall, if you were non-cirrhotic, this was a highly effective therapy. If you were cirrhotic, declatosphere and sofosbuvir didn't pass the mustard, as we would say. And looking at Ally 3+, where you went longer, you were able to increase SVR rates in cirrhotics by going longer than 12 weeks. But remember, Ally 3 stopped all therapy at 12 weeks, irregardless of the presence or absence of cirrhosis. So let's jump into the newest approvals and the newest data. The newest approvals actually within the last month. Sofosbuvir, valpatisvir, and voxilavir, the triple combination was FDA approved at the end of July for retreatment of DAA experienced patients. And glecaprevir and pibrentasvir was actually just approved 2 weeks ago as a two-drug combination for all phenotypes of patients, with the only exception being it being contraindicated or not recommended in decompensated cirrhosis, Child's B or C. We'll focus a lot on glecaprevir and pibrentasvir because it has labels for a broad population of patients. In fact, about 95% of patients can be treated effectively with this new combination. And then the phase 3 up and coming, the last of the last as it comes through the development pipeline is uprifosbuvir, grizaprevir, ruzasvir as a triple, and uprifosbuvir, ruzasvir as a double. So a polymerase and an NS5A, a polymerase, a protease, and an NS5A. So here's the glecaprevir, pibrentasvir. These are both what I would call next generation compounds. What do I define as next generation? Two important factors that really define it. Are you pangenotypic? Can you work across all genotypes? And are you responsive to resistance-associated substitutions that have been seen with the first wave drugs? So in NS5As, can you treat the positions 28, 30, 31, and 93 RASs? And if you're equally responsive to the first generation RASs and you're pangenotypic, that defines next generation compound in my mind. So both of these compounds fulfill this definition. Glecaprevir, a protease inhibitor, pibrentasvir, an NS5A. They're hepatically metabolized, so they're also an option in renal patients. And let's talk about it. So does anybody remember this book, or their kids remember this book? Donde está Wally? So with pibrentasvir and glecaprevir, there was 2,256 patients in the phase 2 and 3 program. There were only 22 virologic failures, 22 of 2,256, which is, I won't have you pull your phones out to do the math, I'll do it for you. It's 0.9% virologic failure rate. So to me, finding the virologic failures with glecaprevir and pibrentasvir is just like trying to find Wally in this picture, right? There's virtually everybody is a success, and there's just 1 or 2 failures. In fact, those 22 failures out of 2,200 patients in the whole program, there's 2 genotype 1 failures, 2 genotype 2 failures, and 18 genotype 3 failures. There are no 4, 5, and 6 failures across the whole program. 100% of patients responded who were genotypes 4 through 6. So this is really, we've gone from the world of 95% to almost universal success with virologic failure rates of 0.9%. Yes, that's less than 1%. I never thought in my career we would be in this position when we started with peg interferon and ribavirin in the IDEAL study in 2004 at 50%, right? So let's go through some of the data, because this may be data that's new to you because it's the newest regimen on the market. And so the endurance program is the non-cirrhotic program for pibrentasvir and glecaprevir. And the endurance program, they did the same thing. The endurance 1 is genotype 1, endurance 2 genotype 2. Surveyor 2 part 4 is genotypes 2, 4, and 6. There is an endurance 2, but endurance 2 looked at 12 weeks. Surveyor 2 supported this 8-week data. As I show you the data, the outcome of this is that non-cirrhotics are indicated for 8 weeks. So we're getting this 99%, 98 to 99% response for 8 weeks of therapy in all non-cirrhotics and 12 weeks in cirrhotics. So this therapy is highly effective in endurance 3, genotype 3, endurance 4 is genotype 4 through 6. And as you can see in the numbers, the MITT, or the virologic failure rate, are virtually non-existent. So whereas Wally, there's one failure out of these 700 patients in endurance 1, there's one failure. That one failure out of the 700 patients was at 8 weeks. You may say, that 8-week patient should have went longer and maybe he wouldn't be the one failure, but you would be wrong. Why? Because that one failure was a breakthrough. He wasn't a relapse. So it wasn't a duration-related failure. It was actually a failure irregardless of being treated for 8, 12, or 100 weeks. If they were a breakthrough, they would have failed no matter what the duration. So this really demonstrated that a genotype 1 patient treated for 8 weeks had universal success, and thus the indication for non-cirrhotic patients in genotype 1 being treated for 8 weeks with this 99.7% response rate. Looking at genotype 2, there was a 99% response rate. You can find the 2 Wallies in the endurance, Surveyor 2, part 4. There's the 2 genotype 2 non-responders came out of this trial. They were both relapsers. Another 200 patients who were genotype 2 had a 100% response rate. So between these 2 studies, there's the 300 patients with only 2 genotype 2 failures. Endurance 4 with genotypes 4 through 6. I told you there were no Wallies in genotypes 4 through 6, so the trial had to have a 100% response rate, and it did. And then we'll look a little at endurance 3 because genotype 3 is kind of the stress test for any regimen today, right? Genotype 3 is the hard one. So this study was nicely designed. It compared declatosphere, sofosbuvir, and treatment-naive non-cirrhotics. Remember, I pointed out that 98% from soft DAC to remember from the registration trial. So this was a comparison in that same population. The expected response rate was 98%. So they could have compared it to sofosbuvir and ribavirin with an 80% SVR and guaranteed a win. But the manufacturers decided to actually go for the gusto, compare it with the most effective regimen that was available, which was declatosphere and sofosbuvir, with the knowing that they were going to get potentially a 98% response rate. So this was clearly a trial of non-inferiority and not superiority, because you can't prove superiority over 98%, right? You need 10,000 patients to have a p-value from 98 versus 99. So the sofosbuvir declatosphere was compared to 12 weeks of glecaprevir and preventosvir versus 8 weeks. They made these names particularly hard so that you'd have to say them 10 times and think. So I like to say GP because after about the 8th time I start tripping over glecaprevir and preventosvir. So I'll say them GP, which is easier for me. So what was the result in these genotype 3s? That 12 weeks was non-inferior to soft DAC. And of GP, and 8 weeks of GP was non-inferior to 12 weeks of GP. So overall, we saw very similar to Astral 3, right? 95 to 97% response rates with this therapy, and it was non-inferior to sofosbuvir declatosphere. How about adverse events? Adverse events causing discontinuation, the number I always like to look at. Soft DAC, 1% discontinuation rate, and very similar rates of early discontinuation rate with the new therapy, preventosvir and glecaprevir. So adverse event profiles that looked very similar. Endurance 2, which I don't have a big slide on, but it was placebo-controlled, and the Endurance 2 placebo arm looked, again, very similar to the active arm of glecaprevir and preventosvir. So that was non-cirrhotics with 98 to 100%. Here's cirrhotics. Cirrhotics looking at genotype 3 and non-genotype 3, just like we've looked at in the field. So in the genotype 3 patients, either treatment naive or treatment experienced, 100 or 96% response rates. And Expedition 1 looked at the genotypes 1, 2, 4, 5, and 6. Let's look at Expedition 1. Expedition 1 looked at 12 weeks open labeled in cirrhotics who were any genotype with the exception of genotype 3. And we found the second genotype 1 Waldo. Here he is. So there was one failure, an endurance one in the non-cirrhotic 8-week arm who failed by viral breakthrough, and the only other genotype 1 failure in the whole program is one cirrhotic genotype 1 patient in Expedition 1. I already showed you the 2 Wallies in genotype 2. They were in Surveyor 2 Part 4, right? They were non-cirrhotic. So I said there were only 2 total, and I showed you 2. So clearly all the genotype 2 patients responded even in the setting of cirrhosis, which they did. And I told you there was no Wallies in genotypes 4 through 6. And of course, all the cirrhotic 4 through 6s responded, albeit the numbers of 5s and 6s they found was relatively small. Genotype 5 particularly is challenging to find once you leave South Africa, but there are just a handful of genotype 5 patients around the world. So is there any additional safety issue in the setting of cirrhosis? People will say, well, glecaprevir is a protease inhibitor, it concentrates in the liver. Are you getting more adverse events with this protease inhibitor as the cornerstone of this regimen? And the answer is no. The adverse event profile looks very similar in the non-cirrhotics as it does in the cirrhotics, and early discontinuations from adverse events were 0. So clearly, even in the setting of cirrhosis, there was no incremental increase in rates of adverse events. Finally, let's look at special populations. There aren't too many special populations left. Every special population is not so special anymore, irrespective if you're co-infected. We now treat co-infected just like mono-infected, and really all these, what we labeled as special populations, are really responding just as well as the non-special population. So we really we're getting rid of this term special population as the number really start falling. But in this realm, we'll talk about Expedition 4, which was in advanced kidney disease patients again. Remember, I talked about the Merck combination in the C. surfer study being great in genotype 1s, but it was only genotype 1 specific. Remember, in genotype 2-3 dialysis patients in the US, what were we still using before the approval of this? PEG-RIBA. There are no safe DAAs in genotype 2 and 3 dialysis patients because everything was sofosbuvir-based, which you couldn't use in dialysis. So this is really an important step forward for the genotype 2 and 3 patients who now are the final population that actually get away from PEG-RIBA. It took 2017 to actually eliminate PEG-RIBA from the US, and now we have done that by having a pan-genotypic regimen that's safe in kidney disease with Expedition 4. And then Magellan 1 is in DAA failures, Magellan 2 is in post-renal and post-liver transplant patients. Post-renal and post-liver transplant patients, 99% MITT, and Expedition 4, the renal patients, 100%. There were no virologic failures. There were 2 patients that didn't end up showing up for their visits, but looking at virologic failures, there were none. So this is, again, a highly effective therapy in those with advanced kidney disease, a very big step forward. DAA experienced patients, looking at 12 versus 16 weeks, what we learned with this combination is if you're a PI failure only, you do well. If you're an NS5A failure only, you do well. But you don't do well. This is the part of the 5% we don't want to use when glecaprevir and preventosvir. If you failed both an NS5A and a PI, you don't get the response rates you want. So this is not the therapy in combination antiviral failures. The 5% of patients that shouldn't get preventosvir and glecaprevir are Child's B and C, any decompensated patients, and any patients that have been exposed to an NS5A and a PI. Otherwise, this is a highly effective therapy across any patient type. Those are the only 2 patient types you can't use or shouldn't use this regimen: decompensated patients and combination antiviral failures with an NS5A and PI. Sofosbuvir, valpatisvir, voxiloprevir. This is the Astral study plus a protease inhibitor, right? This was approved recently in the US, but only for DAA failures. So this is actually a better choice in combination therapy failures. And I'll show you the difference here. The NS3 only with the triple, good again. NS5A with the triple, again good. But here's a difference in the 2 glecaprevir and preventosvir, right? I showed you 80% here. Here with 3 drugs, you're able to get up to 97%. So this is the right therapy for combination DAA failures. If you've been exposed to a PI and an NS5A, this is the therapy you want to use in your patients. This is the up-and-coming triple, which I won't discuss due to a lack of time here, but next time you ask me to present data, we'll go through the data on this. So overall, in conclusion, this really the definition of second-wave regimens to me are pan-genotypic and effective against resistance-associated substitutions of first-wave therapy. This is an area of highly active drug development that has been highly active. It won't be so active anymore because you can't cure more than 100%, and we're about there, so there's not much more room for improvements in our therapy unless we can get durations down to very short durations. Maybe we can move into like the HIV world has with nanomolecules of a single injection that will cure everybody's hepatitis C, but from traditional standpoint, we're not going to get much better. We have all oral regimens that not only cure above 95%, now are approaching 98 to 100%. Although HIV used to be considered a special population, it's not so special anymore. HIV recommendations are the same as mono-infected patients, and even glecaprevir and preventosvir in a non-cirrhotic, the label supports only 8 weeks of therapy in even co-infected patients, which was the only therapy that we would have given 8 weeks for in a co-infected patient. And this is a field that moves very quickly. If you don't want me to come every 6 months to update you, you can actually find the information on the AASLD IDAC guidance document. That's a living document on the internet with that reference that's there. And the only other topic I didn't cover due to time is drug-drug interactions. Although drug-drug interactions are becoming less, there are still drug-drug interactions you have to understand, particularly with CYP3A4 inducers and PGP inducers. These can degrade the antiviral effectiveness and can take you from your 98 to 100% significantly down if you combine these antivirals with very potent CYP3A4 inducers or PGP inducers. So there's a great drug-drug interaction site that's listed here. And finally, everything is bigger in Texas. And here's a taco we had in Texas. I'm looking for a bigger one here in Mexico, but so far I've had the biggest taco I found in Texas. Thank you for your attention. It's always a pleasure to talk to you.